Um, but let's move on. Okay, objective 15. Define the following terms. Ventilation to perfusion ratio. It can be abbreviated as V/Q. Tidal volume, physiologic dead space, respiratory rate, dead space ventilation, minute volume, referring to ventilation, alveolar ventilation, anatomic dead space, and alveolar dead space to tidal volume ratio. I know a lot of these terms sound pretty big and sophisticated and intimidating, but actually the concept is quite simple. So let's move on to what all of this means. Ventilation, efficiency, and effectiveness. Even in healthy lungs, ventilation is not entirely efficient. We know that because as respiratory therapists, we have to give medications to make breathing better, especially in our COPD and asthmatic patients. A substantial volume of inspired gas is what we call wasted with each breath, and this wasted ventilation is what we refer to as dead space. Okay? So previously we learned that gas moves in and out of the lungs through the same airways leading to the gas exchange unit, which is down at the alveoli. We know down at the alveoli area, AC membrane is where the diffusion takes place, perfusion happens, and the gas exchange takes place as well. For each inspiration, gas left in the conducting airways is what we call anatomic dead space. It does not participate in gas exchange. In effect, is what's considered wasted. So I'm going to say that again. For each inspiration, the gas left in the conducting airways is what we call anatomic dead space. And it does not participate in gas exchange and is considered wasted. So let me see if I can share with you my slide from Unit 2, okay? Unit 2, we had the trachea, which is up here, okay? And down from the trachea, let me get rid of that a little bit, oops, go back. That little area here, go from the trachea down to the right and main stem, left and main stem bronchus, and it leads down to the other areas, which eventually leads down to the alveolus. We know that by the 17th generation is where it leads to the terminal bronchioles, and after that is where the gas exchange takes place down at the alveoli. However, when we're looking at generations from the trachea down to generation about 16, all of this area in here is what we call conducting zone, meaning it just like a train, it just carries the air down to the area where gas exchange is going to take place. All of this air here is what we call wasted air because it's not being used for anything, and therefore we call it dead space. So that's where the term comes from. Dead space is not being used, dead area, it's not part of gas exchange, thus the term. Okay, let me go back and see if I can go back to my slide. Okay, here we go. So for each inspiration, as I said, the gas left in the conducting airways, which we just reviewed, is called anatomic dead space because it does not participate in gas exchange and effectively is what we call wasted gas. So what exactly is alveolar dead space? Well, alveoli that are ventilated but has no perfusion contribute to what is called alveolar dead space. I'm going to say that again. It's the alveoli, we know where the alveoli is in the respiratory zone, that are ventilated because we have several different levels of dead space. It's not just dead space in the conducting zone, but even down at the alveolar area, think of Porzakon and the Lambert situation where it could be blockages and then the connecting areas can't communicate to each other. That's kind of what's going on here is what we call alveolar dead space. So alveoli that are ventilated, ventilation takes place, but the blood flow that goes across where the alveoli is not happening. And this is a form of what we call alveolar dead space. There's another type of dead space. This is called physiologic dead space. And this is the relationship between dead space volume, which we abbreviate as VD, And alveolar volume, which would be abbreviated as VA, you may even see a little dot right in the middle of the VA. I can't always replicate some of those abbreviations if it's not part of the symbols in the software. But you may see V with a dot in the middle, A, can be expressed as physiologic dead space. And the equation for physiologic dead space is tidal volume equal alveolar volume plus dead space volume, okay? So the greater the dead space, the less efficient the tidal volume will be at eliminating CO2. So if a person is really huffing and puffing and they're not giving themselves enough time because they're breathing so fast for gas exchange to take place at the alveolar level, that makes those passageways, even though they're close to the alveolar gas exchange level, they can also become dead space areas because they're huffing and puffing and not giving their body enough time to do what it needs to do. And therefore, which would hinder the elimination of carbon dioxide on exhalation. So this is a picture example of how you can see where there's some ventilation going on and perfusion by the arterial blood. So we see here, this is what's called anatomic dead space. This is the conducting zone, okay, leading out to the conducting zone. And from here down to here, I'm sorry, this whole area, here to here is anatomic dead space. Here down to here is what we consider physiologic dead space. And from here down to here is considered alveolar dead space, okay? So the venous blood comes in. We know that from unit 3 when we talked about the cardiac cycle. The blood will come in from the right atria, from the superior and inferior vena cava. Do its little thing, goes through the chambers, and then the right atria, then the valve, and then the right ventricle. Then it goes up through the pulmonic area, and then down into the lungs. And then this is where we will see the gas exchange take place. So we have venous blood that gets oxygenated, and then it comes out as arterial blood, okay? So let's look at some of the terminology for ventilation that we need to know. So we got minute ventilation. You'll hear about this your whole program because minute ventilation is very involved in our ventilation with the ET tubes and the respirator, okay? So the term minute ventilation means the total lung volume moving in and out of the lungs per 1 minute. How much total volume is moving in and out of the lungs in 1 minute? So as you breathe in, then you breathe out, and how many times you breathe in, and then you breathe out, and then we count up to a minute, and that can be, it's a little equation we can do, what we call minute ventilation. It can be expressed by calculating respiratory rate, so how many times you breathe in, and you breathe out within a minute, and then also the amount of tidal volume, which we know is the amount of volume we breathe in through our lungs in one breath. Okay, now it's all kind of coming together. We're using a lot of respiratory terms here. Normal values for minute ventilation falls between 5 to 8 liters per minute. Okay, so minute ventilation, the equation is respiratory rate times tidal volume. Remember that for the whole program. And the normal values for minute ventilation is 5 to 8 liters per minute. So when we think of respiratory rate, we're referring to the number of breaths per minute. Tidal volume, as a review, is the volume of gas in one normal breath as you breathe in and then you breathe out. That's considered tidal volume if you was to measure that volume that goes in and then out of your lungs, okay? That's the same volume that we will use on our ventilator based off of ideal body weight. Because remember, big body don't mean big lungs. We have to figure out their sex as far as male or female, and then approximate height, and then we can just figure out from that point what would be their ideal body weight, and then we can calculate their tidal volume, predicted tidal volume. Now we're going back into the anatomic dead space. What exactly does that mean? Well, anatomic dead space is the gas volume occupying the airways. And remember, it does not take place in the gas exchange part of the body. Most adults have about 150 mLs of dead space. So the conducting zone in general holds about 150 mLs in a typical adult. Dead space ventilation is another part that does not take place in gas exchange, okay? So we take the part of the minute volume, and then we look at the respiratory rate. So the equation for that for dead space ventilation within a minute is respiratory rate times tidal volume and atomic dead space, okay? Alveolar dead space. Alveolar dead space means the alveoli that are ventilated but are not perfused by the blood that goes across. An example of what that would be, if you was to think of a situation as pulmonary embolism or emboli, that means that the person has a clot in their lungs and is blocking the perfusion because of the blood clot. Okay, so they're breathing in and out okay, but gas exchange is not taking place to get rid of the venous blood so the good oxygenated blood can flow across. Okay. Physiologic dead space, combination of anatomic dead space and alveolar dead space. When we're thinking of that, I showed you that picture. And the alveolar ventilation, which is abbreviated VA, the part of the tidal volume that does not take place in gas exchange at the alveolar level, we're referring to like good fresh air. It doesn't happen down at that area. A lot of that can have to do with how fast the patient's breathing. If they're breathing slow enough that gas exchange can take place. If not, it can cause a problem. But in this case, we're thinking of alveolar ventilation. The tidal volume that does take place in gas exchange is considered alveolar ventilation. But it can cause a dead space situation if a patient breathes too fast. And I'll explain that later. Don't mean to confuse you if I'm saying things that sound alike. A lot of terminology here. Okay, ventilation to perfusion ratio, we abbreviated VQ. It's the ratio of ventilation to perfusion. Normal value for that is 0.8, or what will be considered 4 liters of alveolar ventilation and 5 liters of perfusion. We're referring to cardiac output perfusion. So you would, to the lungs, so you would take 4 liters divided by the cardiac output, and that will give you the 0.8, which is the normal value. That's how they come up with that number. More terminology here. Dead space to tidal volume ratio is abbreviated VD to VT, and we're referring to the relationship between physiologic dead space to tidal volume. Normal value for this is 0.3. 30% of the tidal volume is dead space, or 150 mLs, which we already said. A typical tidal volume, as a review from previous, is about 500 mLs. Most adults at rest breathe about 500 mLs. And of that 500 mLs, 150 of that does not make it down to gas exchange. Only about, I would say that's probably about 350 mLs makes it down to the alveolus for gas exchange. The rest of it is what we would consider dead space. It's just sitting in the area, doesn't go anywhere. So you fill up with your lungs with air, and as you fill up your lungs with air, only part of it actually makes it down to the alveolus. The other part is just keeping you full. Okay, 350 mLs make it down to the alveolus for gas exchange. The other part is just moving in and out as part of the conducting zone, which is dead space. So if we was to look at the clinical equation for VD to VT, it will be the partial pressure of arterial CO2 minus the partial exhalation of CO2 divided by the partial arterial CO2. So if you was to use normal values for that situation, you would come up with the value that's listed above as 0.340, which is partial arterial CO2 normal value minus exhalation CO2 divided by the normal value for partial arterial CO2, and that gives you the 0.8. That's where those numbers come from. So in healthy subjects, alveolar ventilation changes with breathing, deals with the rate and the tidal volume because the dead space is relatively fixed. So when they say relatively fixed, they're just talking about, just like I said before, in a typical breath for most adults, the tidal volume is 500. Of that 500, only 350 makes it down for gas exchange. The fixed part is that 150 mLs that sit in the conducting zone as dead, wasted area that's not used for gas exchange. That's all they're saying. In all adults, it's always fixed. That's what it is. Every adult has 150 mLs, scientifically speaking. So if a person was to have a high respiratory rate and low tidal volume, it results in a high proportion of wasted ventilation, per minute volume, which cause a low alveolar ventilation. So if I have a patient that's huffing and puffing because they're short of breath, they're breathing maybe 28 to 30 times a minute. They're breathing because their body is doing what we call a fight or flight. It's trying to fix whatever's going on, is making them short of breath. And the body is responding by having a person breathe fast. However, because they're breathing so fast, they can't take in that nice deep breath, which will be about 500 mLs. They're probably only taking about 250 mLs, maybe even 300 mLs, because they're trying to breathe so fast. There's no way you can take a nice, slow, deep breath of 500 when you're huffing and puffing. So because of that, and they're cutting the amount of time down at the alveolus for gas exchange, that area, because they're breathing out so quickly, will be considered wasted ventilation, because only part of the gas exchange is happening because they're huffing and puffing. And it will cause them to have what we call a low alveolar ventilation. So you can see here, typical adult. This is the conducting zones, which is from the trachea up here at the top, okay, leading down to the right and left main stem, okay? So we know this is what's considered the conducting zone, because it's just conducting air, carrying it down to the alveolus area. 150 mLs, it stays in the conducting zone, and the other 350, when a person's full, goes down to the alveolus for gas exchange. So we have a person that's breathing pretty fast, about 24 breaths a minute. We know normal breathing is 12 to 20 breaths a minute, right? So this person is what we would consider a little tachypnic. And then if we was to measure their tidal volume, because they're breathing so fast, they're only breathing about 300. We know most patients breathe about, when they're resting and breathing normal, on an average about 500. So we know that they're not effectively breathing like they should. So we take that dead space, which is 150 mLs, and only because of that dead space minus the 300, we have only 150 mLs that's making it down for gas exchange. And as a result of this, because they're not giving their body enough time for the gas exchange, for the CO2 to unload and the O2 to load, they're going to do what we call retention and hold CO2, and it's going to go right back through into the body because it's passing through. It's not happening. It's going to go back into the systemic system. And if we use to draw a blood gas, we will find results showing that their CO2 levels are going up because they're not giving their body enough time for gas exchange to take place down at the alveolus area. It's just carrying over, and whatever can be picked up within them breathing in and out so fast is what's going to be picked up, and the rest of the CO2 is going to be retained. Hopefully that makes sense to you. If not, I can explain again later, or your substitute can kind of elaborate on that just a little bit. Okay, so generally, the most effective breathing pattern for any patient, even you at rest, is slow, deep breathing. We breathe nice and slow. We don't think anything of it. We just do it. We don't think about breathing. It just happens, right? So a healthy person's lungs can compensate for decreasing ratio of tidal volume if they're not in distress. Most of us can do that. If I'm exercising and I'm kind of like, overdoing myself and I'm huffing and puffing, I would normally, I'm not in distress, I'm just exercising, okay? To calm myself down and relax after I'm done with the vigorous exercise, I would take slow, deep breaths to get my body to kind of regulate and get back to normal. That's what we normally do. However, when somebody has distress due to inflammation, bronchoconstriction, infection, they may not always be able to slow themselves down like you and I would do normally because we have no problems. So just in general, dead space will increase with exercise, but you usually can recompensate and fix yourself afterwards. Physical exertion and pulmonary embolism. You know why with that? Because there's a clot in the lungs, your body's trying to fight to fix it, right? So let's take a look at another situation. So we have a patient, we got the general 150 mLs of dead space, right? And this person is breathing, let's say they're taking really deep breaths, nice and relaxed. You just got through exercising. And you say, okay, I'm huffing and puffing and I'm slowing my breathing down and I'm trying to make myself breathe normal. Okay, so I start taking really deep sighs in. And if you was to measure my tidal volume, I would be at about 1,000 mLs. That's double what a typical person would breathe. But I'm not feeling weird about it because I just exerted myself, exercised, and I'm trying to get my heart rate down and I'm slowing my breathing down and I'm trying to get back to normal. So we have a person that measures at a tidal volume of 1,000 mLs and the respiratory rate is 12. Now we know typically every adult has a dead space in the conducting zone of 150 mLs. And of that 150 mLs, if you was to do the subtraction, 1,000 minus 150, that's going to leave 850 mLs that makes it down to the alveolus for gas exchange, okay? Because the person compensated by having a bigger tidal volume, it made it so there was more washout and they're breathing slower, okay? So they're breathing slow, it's not fast. With a huge tidal volume, they're going to cause the alveolar ventilation to balance out. And actually, because the tidal volume is so big, they're going to wash out more carbon dioxide than they need to. That may not make sense to you right now, but I'm going to show you a chart that may bring it all together if it doesn't make sense. So generally, if I breathe in real big and deep and my respiratory rate is at a normal rate, we know respiratory rate is normally 12 to 20. I give my body enough time for gas exchange. Matter of fact, too much time for gas exchange for such a big tidal volume. I'm going to wash out more carbon dioxide than I need to. Okay, moving on. So elevating tidal volume increases the elastic work of breathing. However, increases in O2 consumption by respiratory muscles, and some patients cannot meet the demand and they get into trouble. So you have a person, they're having an increased work of breathing. Increased work of breathing causes increase of O2 consumption because they're huffing and puffing, they're using a lot of energy. And the person's huffing and they're puffing and they're trying to breathe, get their breathing under control, and they just can't. They're wearing themselves out. Their lungs are getting tired. Their muscles are getting tired, a lot of accessory muscle use. And the patient sustains at this level, they're not going to be able to keep it up. They're going to do what we call tucker out or poop out, and they're going to eventually respiratory arrest because they just cannot sustain. So in some of these patients, these increased demands cannot be met. They only can do it for a little while. The body does this fight or flight thing where it's trying to fight to live. But if it's sustained and we don't intervene, putting them on a respirator, putting them on BiPAP, non-invasive ventilation, which you'll learn about later, the muscle's going to get tired and they're not going to make it, and they can code or arrest. So when we're thinking of pulmonary disease, there is an increase in physical dead space physiologic cause a decrease in alveolar ventilation, unless some kind of way these patients can fix themselves and some kind of compensation occurs. Maybe give them sedation to relax them. We put them on the ventilator, non-invasive, things like that. We got to do some type of intervention when these patients have pulmonary disease, asthma, COPD, emphysema, things like that. Because they're huffing and puffing, they're creating larger dead space that's only meant to be in a conducting zone, even down closer to the alveolar level, because they're huffing and puffing so fast, they're not giving their bodies enough time for gas exchange to take place to regenerate and oxygenate. So effective compensation for a situation like this, for increased dead space, physiologic, requires them to increase their tidal volume, just like what I talked about with the person that's exercising. That would be the way they would balance their body, is to increase their tidal volume and reduce their respiratory rate, or increase their tidal volume and some kind of way balance it out. So what happens next? You got somebody huffing and puffing. They can't compensate, or maybe they can compensate. So in such cases, alveolar ventilation may be inadequate to meet the body's need, and CO2 is not removed as rapidly as it is produced, to kind of summarize everything that I'm talking about. So what happens because of this? They have a CO2 retention, which leads to what's called respiratory acidosis. And if they don't have mechanical ventilation support to kind of balance that out and make them breathe the proper way, they're going to have what's called a decrease in pH balance, and they're going to have an increase in CO2 retention, which leads to what we call in the blood acidic situation, which is called acidosis. As you learn blood gases, we refer to it actually as a respiratory acidosis, because this is coming from the respiratory side where it happens with ventilation. So this chart here gives you some examples of different scenarios with ventilation and how the body can compensate if the person was to adjust their tidal volume. So let's take a look here. So we have a person here that have a tidal volume of 12, which is normal range, right? And then we have a tidal volume of 5, which is normal range. And then we have a minute ventilation. Remember what the range for minute ventilation is? I believe it's 5 to 8 liters per minute. So we know that's normal too. And then we have the physiologic dead space here. In every adult, typically if they're not in distress, then the conducting zones is 150 mLs. Normal alveolar ventilation, if everything was proper, is 4,200 mLs, or what we would say 4.2 liters. So let's look at the next situation. So let's say we have a person who's a little tachypnic, their respiratory rate's 24. Because they're breathing so fast, it cuts down their tidal volume to only 250 mLs if we was to measure it. And then we still have a minute ventilation of about 6,000 mLs, because remember, respiratory rate times tidal volume gives you your minute ventilation. And then we have the typical dead space of 150. Well, look what happens here. Because that tidal volume is cut down and they're breathing fast, the alveolar ventilation is not as effective, and it's actually cut in half almost, 4.2 liters or 2,400 mLs. So this person is not adequately ventilating, okay? Let's look at the next situation. We have a low rate, high volume. So the person is breathing 6 breaths per minute, which we know is not exactly ideal, but however, their body's not in any trouble because they're taking this 1,000 ml or 1 liter tidal volume, which is double what a typical person would do, right? As a result of that, their mental ventilation is still stabilized at 6,000 mLs or 6 liters. And their physiologic dead space in this case is still about 150. But we know normal alveolar ventilation is 4.2, but in this case, their alveolar ventilation is 5.1 liters or 5,100 mLs. Well, they're actually overventilating a little bit because their tidal volume is so big. It's kind of compensating and balancing everything out. So let's say, for some reason, it could be some kind of blockage in the lungs. This person has increased dead space. It could be mucus plugs. It can be anything causing that, okay, where the ventilation is not happening, plug in the bronchioles. So in this situation here, this example, let me find my little cursor. We have 12 as the respiratory rate, which we know is normal. Normal tidal volume at about 500 mLs. And our minute ventilation is still about 6,000 mLs. But in this case, for whatever reason, or mucus plug or some type of inflammation is causing an increase in physiologic dead space. It's double what it normally should be. And as you can see right here, it affects our alveolar ventilation quite a bit. It actually cuts in half. So the person's still not ventilating right. That's why it's always important for us to do bronchial hygiene, clearing mucus, recruiting alveoli to make them function properly and ventilate okay. And if they don't have that happen, all those areas are considered dead space if they're not ventilating. And look what happened here. Our alveolar ventilation has actually decreased. Let's look at our last example here. We have what is called compensation for increased dead space. So we have a person here who's breathing normal respiratory rate, but they're taking typically a little bit bigger tidal volume than you normally would. It causes their minute volume to go up to 7,800 mLs. But they do have some problems with dead space in other areas of the lung for different reasons. Mucus plugging, alveolar, atelectasis, who knows? But they got more dead space in their lung than it should be. But because they're taking that bigger tidal volume, the body's able to compensate, and their alveolar ventilation is actually in normal range, which is 4.2 mLs. So the patient can compensate, but in order to do that, they have to adjust their tidal volume to be able to take a deep enough breath to give their body enough time to have the gas exchange. And if there's extra dead space, they have to take a big enough breath to compensate for the dead space volume as well. So alveolar ventilation depends on height, weight, sex, and body surface. But on average, it's about 4.2 liters per minute. So if your review says, what is normal alveolar ventilation? Here it is, 4.2 liters per minute. And if you was to use normal values, a healthy adult with a respiratory rate of 12, tidal volume 500 mLs, and physiologic dead space of 150 mLs, you will be able to come up with plot in these information, and you will be able to come up with your patient's alveolar ventilation to see how well they're ventilating. So VA equals respiratory rate times, in parentheses, tidal volume minus dead space. So really there should be parentheses here. You're going to do this part first, take the tidal volume minus the dead space, and then you're going to multiply it by your respiratory rate. So let's see how that looks. If you was to calculate alveolar ventilation, this is objective 16. Alveolar ventilation equals respiratory rate times tidal volume minus dead space. And remember, we will have parentheses here. In this example, we have a respiratory rate of 12, tidal volume 500 mLs, and a dead space of 150 mLs. If we was to do the equation, alveolar ventilation equals 12 breaths per minute times, and then of course, as I said before, you would do that section tidal volume and dead space in parentheses first, 500 mLs per breath minus 150 mLs per breath. The breaths will cancel out, and that will be 12 times 300 mLs, and then you equal 4,200 mLs per minute, or 4.2 liters per minute. That's how you will come up with that. So this is the end of section C. I'm going to share another part here with you, if I can find it. Your substitute is going to give you a worksheet, if we were able to get that far in class before class ended. And your worksheet, you're going to actually work on calculating alveolar ventilation. And then you're going to let me know, based off of your results, whether or not the patient has increased CO2 or decreased CO2. So if you have an increase in alveolar ventilation above normal, it's going to wash out more CO2. If you have a decrease in CO2, alveolar ventilation below what's normal, we know what the normal values is because it's in our PowerPoint, 4.2 liters per minute, then you're going to have CO2 retention and you'll have a decreased CO2. So it's a two-part thing to this worksheet. You're going to do the calculation, which is right here in the corner. Always give you all the information that you need. Calculation's right there, okay? So let's look at the first example. Calculate Mr. Jones' minute alveolar ventilation given the following factors. So our respiratory rate is 12, tidal volume is 500 mLs, and atomic dead space is 150 mLs. So you're going to plot all those factors into your equation. 12 is going to go there, times 500 mLs is going to go there, minus 150 mLs there. You should come up with 4.2 liters per minute. So this alveolar ventilation maintains a CO2 of 40 milligrams for Mr. Jones, which is normal, millimeters of mercury, I'm sorry, which is normal for Mr. Jones. So Mr. Jones has normal alveolar ventilation. He would not have any retention, and in this case, his CO2 will be normal. So if you have, after you figure your problem, plot in the numbers into your equation, you're going to say what effect on minute alveolar ventilation and CO2 would this have? Well, if it's a higher number than normal, then it's the increased alveolar ventilation and the CO2 is going to be decreased. And if it's lower than normal alveolar ventilation, then you're going to have a decrease. You're going to have an increase in retention. Okay, so decrease alveolar ventilation, increase CO2. If your alveolar ventilation is higher than normal, then you're going to have a decrease in CO2. And your substitute can kind of elaborate on that if you have a little trouble or don't quite understand. Okay, any questions that you have? If you have any questions, please let me know. I'll go over this again the next time we come together, and I'll do a review and we'll do a Kahoot. Have a great day, and I will see you next class time.